I'm Phyllis Saarinen, a former member of OCAMIC, but I'm here. You'll become very familiar with my face, I think, because I'm here with ILR a great deal. At any rate, I'm very pleased to introduce Scott Darius this morning. Scott is the executive director of Florida Voices for Health. He began his career in health advocacy in 2012 with a major in political science in 2010 and a law degree from UF in 2013. So he began his career when he joined Florida Consumer Health Action and Information Network, or CHAIN, where he helped to coordinate the statewide campaign for Medicaid expansion. And I might add that's still ongoing, of course, with a petition for a state constitutional amendment, which would basically force the state to adopt Medicaid expansion and accept the federal money in the terms of billions of dollars, which would be available to support Medicaid. So with pleasure, I'm introducing Scott Darius.
Awesome. Good morning. There it is. There it is. I got you. You just have to hold it real close. I might start singing. This puts me in a mood to do a Sinatra, but I'll spare you. Good morning, guys. I'm Scott Darius, Executive Director at Florida Voices for Health. And actually, that works. Okay. So just, you know what? Let me start here. It's always weird to like give a presentation or to be in a room of people right after something big happens in the world, right? Like it feels worth acknowledging that, yeah, what a crazy thing. We all survived the storm together, but there's so many people who weren't as fortunate and are dealing with tough times now. So just to say, it's nice to be in a room with folks. This is what gives me hope. Knowing how many terrible things are happening around us, it's nice to be in a room with people who are just trying to do the good thing and, yeah, contribute a little good to the world. So with all of that, to introduce you to Florida Voices for Health very quickly, we're a health advocacy organization. Our mission is to increase access to healthcare for low-income and middle-income Floridians, but I think anyone who's had any interactions with the healthcare system, regardless of how much you make, you have a sense of how broken the system is, right? Everyone, I think, has had one experience or another, or family members, and you have a sense of how many things need to be fixed. And so we try to work on all of those issues. The way we try to do it, I think, boils down to two things. One is coalition building. And so we're very fortunate to work with great partners around the state, building up these different issue campaigns. But at the heart of who we are, how we actually try to move the needle on policy, it really comes down to connecting to people who have their own stories and giving them the opportunity to share those stories in those places where it might make a difference. So we take folks up to Tallahassee, we take them to meetings with their legislators in district, we host press conferences. Yeah, just anything to really build up this narrative about what's actually happening on the ground, as opposed to, it will surprise nobody in this room how distant legislators are, right? Like the policymakers, the people who make the rules, how little they understand about how things are actually playing out on the ground. And so we try to bridge that understanding by bringing storytellers to them. So with the little bit of time that we have today, as we do policy advocacy, so much of our work is just keeping up with what's happening on the ground policy-wise and making sure that our network is also caught up on those things. So it's my pleasure to share some of that with you today. We'll talk first, we'll look at the Florida healthcare landscape just at a high level. We'll look at what's going on, certain trends and outcomes. And then we'll look at this last legislative session where healthcare was the focus. It was a rare legislative session where healthcare dominated everything. And so we'll talk about some of the bills that passed and all the, what that means for Florida moving forward. And then finally, we'll look ahead to 2025. Legislative session is always around the corner, is what it feels like. And so we'll talk about some of the things that we're working on for next year. And yeah, some of the ways I might trick you all into working with us. There we go. So looking at the landscape just at a high level, right? I think coverage and cost are usually the places to start. And in Florida, you see we have a persistently high uninsured rate. It's about 11% as of 2022. And that's still higher than the national average and actually makes us, I think, the fourth highest uninsured rate in the country. And, it's due in large part, I think, to how expensive care is in the state. Even if, right, and we know the golden standard for healthcare coverage is employer-based coverage, right? Like you get your healthcare through your employment. Even in that scenario, we're paying the highest premiums, right? Like Floridians are paying the highest premiums. So just to say, affordability is a major issue in this state. And we were lucky enough to do a project with the Robert Wood Johnson Foundation early last year, just a survey. And we found that 4 in 10 Floridians were having hardships affording healthcare. And that meant skipping services or just hardships in other parts of their life. What I think the survey misses a little bit, actually, is are folks who did get the healthcare, but then had to skip out on other things, right? Like had to forego food or rent or whatever it is. So just to say, I think affordability is a major issue when it comes to care in Florida. Now, unfortunately, for what we pay, we still have pretty poor outcomes. As you look at this map is from the county health rankings that comes out every year, and I'll talk a little bit about the map itself. But just to say that Florida is lagging behind when it comes to premature death, right? So at the end of life, but also when you look at maternity, which is something I'll talk about a few times as we go through. When you look at what's happening at birth, we have a higher percentage of low birth rates, low birth weights. So again, just 2 random stats, but I think if you go into the county health rankings, you'll start to get a fuller picture of where Florida's lagging. Now, the one thing I always like to bring up, right, is the trouble with aggregated data. You look at Florida at an aggregate level, even if you look at the counties at an aggregate level, you can see where there are some places that these are all the counties ranked against each other. You can see the lighter counties where outcomes are poorer. Keep that in mind. Keep where you see that the lighter portions in mind, and it'll be relevant when we go through another map in a second. But just to highlight real quick, even in these darker colored counties, right, closer to the bottom, I'm from Miami. Anyone else here from Miami? Yeah, there we are. Dozens of us. I like it. There's 2 of us. Just to say, people from Miami always find a way to tell you that they're from Miami. So this is me telling you that I'm from Miami. But being from down there, we know that, right, it's a darker shade of green, but I know that there are pockets, there are neighborhoods within that county that are facing outcomes just as bad as, some of the lighter shaded places. So just to point out the sticking point that happens with some of that aggregate level data. But as we start to drill down a little bit, right, I think it's worth looking at certain populations, and we'll also look at different aspects of healthcare just to really get a full sense of the landscape. And I think maybe the place to start, quote Gandhi. I'm not that deep, but I'll quote Gandhi, right? Which is to say that the way you measure society is by looking at what happens for, I want to say the least of those, but like the people who don't have much. How do we take care of folks at the lower end of the socioeconomic scale? Medicaid is our program to do that, right? Medicaid is our health coverage program for low-income individuals. So my question for you all in the room, what do you think in a family of 3, what's the most the adult in a family of 3 can make for the year and still qualify for Medicaid? So what's that upper threshold? Any guesses? 25,000. I'll start. Okay, 25,000. We'll start at 25. Any other guesses? 30. I like it. Any other guesses? 17. Not bad. What else we got? Any last guesses? You're itching to guess, I think. Phyllis, I feel like, knows the answer. No last guesses? Okay. So the problem is fundamentally that, like, you guys are too nice. You're way too nice. $30,000 for the year, 25, 17, that's crazy. It's closer to 8,000 for the year is the most you can make as a parent in a family of 3 and still qualify for Medicaid in this state, right? I think sometimes there's this perception that if you're low income, you automatically qualify for Medicaid, but I don't think folks really understand just how restrictive Florida's Medicaid program is. Now, if you're a single adult, you don't have any children, doesn't matter how little you make, you do not qualify for Medicaid in Florida. And so, when we think about what we're doing for the least of these, while there are those who, unfortunately are at that point where they do qualify for Medicaid in the state, you can see how difficult it is for them to work their way out of that, right? It's hard to find a job that's going to pay you $10 more that jumps that gap where you get, access to healthcare and tax credits in the ACA marketplace. More likely, you're going to get that incremental raise, right? The one. Hello? There it is. No, we're back. We're back. And so there are almost 500,000 Floridians who are living in that situation where they don't qualify for Medicaid in the state, but also don't make enough to qualify for tax credits in the ACA marketplace. Now, earlier, I asked you to keep in mind that part of the map where you saw health outcomes lagging behind, right? And did anything about that jump out at you? Mostly that they're rural communities. They're among, Florida's rural communities, right? And we know that there are so many others kind of sprayed throughout the state. But yeah, there's that real concentration of, we're up here. We're in North. Normally, I give this presentation not in North Central Florida. So I have to remember, you guys know what I'm talking about. Yeah, but as I'll get into the specific counties in a second, but just to say that us is the way we take care of our rural communities, we're lagging behind a little bit. When you look at providers, just at a provider level, I think we have a third of the dentists per 10,000 people that they do in more metro areas. We have about half of the MDs, doctors in these areas in rural communities per 10,000 people. And never mind the loss of providers, there's also just the loss of access points. You can read here how many rural hospitals we've had close, but we've had 3 of them close since March 2020. Now, I know that's a long time ago, but if you think back to that, right? Like that day, March 2020, and that's a specific time in history, how hard it would be to lose, how hard it was to lose 3 hospitals at that point. Part of what I found out in doing this work is that those hospitals were actually the primary care location for 70% of the population. So just a whole community of folks who don't have any access to care there. As part of our work for Voices, I'll mention quickly, last year, we started diving into this issue of hospital closures just a little bit more. To take you even further back, 18 months ago, my wife did the hard thing and gave birth to our first kid, right? Really amazing moment. A side story to that side story is when I've told this story in the past, it was 5 or 6 months after Glory was born. And so people they're like, oh my God, you had a baby. I'm learning at 18 months, everyone's like, okay, move on. 18 months, there's not like hey, you had a baby. Anyway, but just to say, as we tried to get into the hospital, Bethany went into labor on, I think it was March 21st. We didn't get into the hospital until March 23rd. And it was talking to the nurse who told us that it was because they had such a long list of people waiting to be induced, right? After we lost Shan's Live Oak and Shan's Stark and Shan's, what's the other one? Lake City? Yeah. Yeah, there's nowhere to deliver a baby in a lot of North Central Florida. And so folks are all coming to Gainesville, creating this incredible backlog. And so, yeah, it took us 2 extra days to get into the hospital, which for me is like, I got a little bit of sleep, but like my wife obviously didn't. So just to say, as we did these roundtables to really dive into this issue, we learned that it wasn't, the scenarios I ran in my mind where I'm like, hey, I live 15 minutes from Shan's, but what do I do if I live 90 minutes from here? It wasn't a hypothetical. What we learned is that there were so many people who are actually experiencing that currently, who to this day are like living in this world where they have to travel 90 minutes to 2 hours to get to a hospital. And sometimes that means going up to Valdosta or whatever it is. But people are jumping through incredible hoops to get the care that they need. But as we think about the health landscape generally and like these groups that are facing disparities, we can't skip over communities of color. We know the Florida Department of Health data that, it's still out there somehow. We see that people from communities of color are suffering worse health outcomes at higher rates than others, right? Than their counterparts. We know that 50% of the Floridians who are in that coverage gap I talked about earlier, the 500,000 people, are made up of people from communities of color. And a last point, I've talked a little bit, and as we go through, you'll hear me hit on the maternal health piece once or twice, but just to point out just how bad our maternal care is in this state. Looking at maternal mortality rates, right, per 100,000 people, I think as you can see, the state average is at around 28 per 100,000 people. But to look at different populations, I think for white women, it's 19 point something per 100,000 people maternal mortality. But for Hispanic women, that ticks up to 21.8. But for Black women in the state, that ticks up to 75 per 100,000 people. 75 per 100,000 people. And so a point of personal privilege to like be able to, any space that I'm in, I like to lift this issue up because it's a bad one. And a place where Florida has a long way to go, I think, to do better. Now, that was just looking at different populations, right? I think very quickly to kind of close out this section, just to look at a couple of areas of health as well. Oral health, dental health is a big thing we talk about at Florida Voices, one of our big campaigns. We know that there are over 6 million, I think this number's changed. It's over 6 million now who are living in dental provider shortage areas, meaning there just aren't enough dentists to take care of the population there. We know that so many kids between, I think third grade kids mostly is kind of the marker we look at. How many of them are walking around with cavities, but also aren't getting to the dentist? And the same is true for adults, frankly. Now, the thing is, for the system we have where it's hard to find a dentist, it's hard to afford dental care, to find dental insurance and to do the thing, what we do instead is just allow people to present at the emergency room and folks get care there, to the tune of $500 million we're spending for preventable dental issues in emergency rooms. Now, if you've ever had the displeasure of going to the ER for a dental need, what you'll learn is there's not a dentist in the ER. They're not giving you dental care. They're just going to give you an opioid and send you on your way to take care of the pain and maybe refer you to a dentist you may or may not be able to see. Now, thinking about Floridians with disabilities, this is another area where we're doing a lot of work, where we're trying to talk about the issues here. We know Florida has a slightly higher rate of people with disabilities, and that number is growing all the time. But right, if you're someone with a disability, it's not so much about access to healthcare, to like the medical care that you need, even though Florida does have some gaps in that system. So much of it is about the other services, right? The home and community-based services, we call them, that keep people in their homes, that keep them out of institutions, that let folks live full and productive lives, let them be a part of, what the rest of us are trying to do in society. And the way we provide those services is through, it's a program called the iBudget waiver. And we currently have a wait list of about 22,000 people on that wait list waiting for services. The thing is, I don't think that 22,000 captures the full scope of the need, right? Like, there's no way a list stays static like that for 5-10 years. It's that people are dying off, or people are moving out of the state, or any number of things that keeps that number kind of at the status quo. But I have here that the minimum wait time is about 7 years, but we know that most people are waiting 10, 15, 20 years to get off of this wait list. One of the great advocates who you'll meet later in this presentation, JJ Holmes, got some incredible wins for people with disabilities this past legislative session, but he himself, 19 years old now, has been on the wait list for 17 years. And basically, you have to be in crisis to get off of this wait list. But what's crisis, right? Well, anyway, we'll get into all of that. Maybe the last point to make there is part of what's driving that wait list and the need is just the fact that Florida doesn't invest as much as we can in access to care for people with disabilities. Currently 49th in spending for disability services. But I think we also have a sense of what we're coming out of in terms of, right, like the COVID days, even though it feels like we're still kind of in them. The mental health issues that we're seeing throughout our communities, for adults and for children alike. And it's the same problem, right? The slide all boils down to the same thing, which is people just don't have access to care, mostly because of cost. People are avoiding, right? Stigma is definitely still a big part of this, but there's so many folks who don't get the mental health services that they need because of cost. Another place where Florida's only spending, our spending in this area makes us the 49th in the country in terms of spending for access to mental health care. But it's in this context that we arrived at the 2024 legislative session that happened earlier this year. The the one thing that legislators are required to do every session, right, is to pass a budget. And so it just feels helpful maybe to give us some high level, a high level sense of what happened. It was a $116 billion budget, slightly lower than last year's. We, healthcare is always the biggest part of the budget, and that's something that you'll hear, and it's true. $47 billion is what we have into healthcare specifically. But why I included the little bullet point before that shows you the breakdown of those funds, right? Like where they come from. So often you'll hear healthcare is eating our budget. It's $47 billion. We're spending way too much on healthcare. Listen, I think we're spending more on healthcare than we need to for the outcomes that we're getting. But so much of this $47 billion is actually made up of federal funds, right? The $37 billion of the overall budget that actually is federal funds, most of that goes into healthcare. The way our Medicaid program gets paid for, it's a 60-40 match between the state and the federal government. So we put up 40%, they send down 60, right, of every dollar that's spent. And so, yeah, and then even in that 40% that the state is responsible for, so much of that actually comes from the hospital systems and local taxing districts who put the money together, send it to Tallahassee, and Tallahassee sends it up to the feds for to bring down a match. So just to say, even if our healthcare budget is this, so little of that actually comes from state-only funds. And then the last piece, $1.5 billion this year was set aside for the Live Healthy initiative. And yeah, like I said, this legislative session was a really big one in that it for health advocates like myself, in that it focused so much on healthcare. Now, what drove that, why this was known as the Live Healthy session, Senate President Pasadomo, Kathleen Pasadomo, who's based down in Naples, so Southwest Florida. This was a real passion of hers. She had a series of community conversations over, I guess it was last summer, where she met with a lot of folks and I think walked out with a sense of, hey, healthcare is like the thing I want to work on, and here are some of the policy focuses that I have. Now, you'll see, based on everything you heard about what's happening in the landscape, that we have like a lot of needs in a lot of different places. But that didn't always align with, the way Senate President Pasadomo was thinking about it. On the one hand, I think the thing she was most focused on was the workforce, right? And to be fair, we have a major workforce issue in the state when it comes to healthcare. I don't just think it's in the state, I think it's around the country, but yeah, we're all trying to come to terms. We're all trying to get our arms around that issue, how to best solve the workforce shortages that we're seeing in healthcare. But, there are also so many other needs in terms of getting people the coverage that they need, getting them to, right, knowing that our healthcare system requires insurance as the ticket into the door. How many folks are kind of left out of that system? All that to say, you can read here for yourself kind of how she was thinking about the work going into it. And where we landed, the Live Healthy initiative is actually made up of, by the end, it was 4 different bills that passed, 7016, and I'll go through each of these in a little bit more detail. But 7016 was the big one, the one that included a lot of the workforce provisions, but yeah, a lot of the other things too. And so we'll spend most of our time there. But then quickly looking at 7018, which was focused on healthcare innovation, mostly through technology, behavioral, SB 330, which was behavioral health teaching hospitals. So we'll talk a little bit about what we're doing to strengthen the workforce there. And then SB 1758, which is where we made some improvements to the system for people with disabilities. So yeah, we'll dive into that. Now, there were so many different components of SB 7016. It felt maybe most useful to bucket them into 3 kind of categories. There are workforce provisions, and then there were a couple of requirements on healthcare facilities, and then finally a couple of what I'll call community health provisions. But starting quickly with workforce, right? One of the things we've done, I think, quite a bit as a state, but also around the country, is these loan repayment programs, basically loan forgiveness programs, I'll say. We have 2 of them in the state, one for dental, and it previously only allowed for dentists working in kind of public health settings in underserved communities. It's been expanded to include dentists who are working in private settings, but also in underserved communities, but then also dental hygienists. So more people are now eligible to have their loans repaid if they work in some of these places where people need more providers. There's also the FRAME program for MDs. That's been expanded to include more nurses, but also folks from more behavioral mental health professions. So your counselors, marriage and family, licensed marriage and family therapists, social workers, those types. There's also just more money allocated to support residency programs in more hospitals across the state. Uh, there's also this like creation of a little committee, and it's a tactic you see throughout the bill. But they create these little committees to like study these issues and hopefully come up with more solutions on an ongoing basis. So besides funding more residency slots in the state, there's also this GMEC that's meant to look at, how are we doing a good job of retaining residents, right? Folks will like come get their education in Florida, but how many of them are leaving the state, and what can we do to keep them here? I actually had a very interesting conversation with this guy from a foundation last week, and he let me know that I think it's specific to dental, but it's only 27% of the people who study here who actually end up staying in Florida to provide care. And so we have a long way to go in actually retaining the folks who get their education here. There's also this additional provision for those facilities that become kind of clinical training sites. You lose a little something when you have students learning on the job. You lose a little bit of time, a little bit of efficiency, and so this helps to make some of those places whole by providing them with, I don't know, lack of a better word, a stipend or a reimbursement for having some of those individuals on their staff. I don't know if folks here are familiar with the Acorn Clinic up in Brooker. Yeah. So I also have the pleasure of being on the board of the Acorn Clinic. And just to say, programs like this are helpful, right? Because we're mostly a clinical training site it's hard to provide care in a rural area. I'll say that. So what helps us is having students and folks who are willing to volunteer. And it's programs like that that go a long way, I think, in, making facilities like that whole. But our last workforce provision, there are these multi-state compacts, basically, where if you're a doctor in another state, if you're trying to move to another state that's also part of this compact, you can do that without having to become relicensed and jump through a bunch of hoops to provide that care. Florida has since joined both the medical licensure compact, but also the audiology and speech language pathologist compact, and physical therapists. So now folks can kind of move in between states. But like I mentioned earlier, the workforce shortage that we're seeing here in Florida is happening all over the place. So I don't know how much we're really solving the problem. If we're, by some miracle able to attract more folks down here, what does that mean for our brothers and sisters in other states, right? That we're all we can live in this bubble that is Florida, but maybe there's a larger truth there that we're all dependent on each other. And so what we do impacts each other that way. Just to point that out. Now, quickly on healthcare facilities, I talked again earlier about the challenges we're having in maternal health. Maybe one thing I didn't mention is that 86% of the maternity wards, maternity facilities in rural hospitals, maternity departments in rural hospitals have closed in the last 10 years. 86%. I think that's 17 different hospitals. And that includes the hospitals that have stayed open, but have just decided it doesn't make sense financially to provide maternal care or OBGYN services, right? So as we try to remedy that situation, birthing centers have already been kind of around Florida, but what they did was created this designation called advanced birthing centers, where you'd be allowed to do, there's a little bit more leeway in the services you're allowed to provide. You can do just, a normal vaginal birth for more weeks between 37 and 41. I think it used to just be an even more defined period of time. You can try a C-section if it's low risk and it's pre-planned. And you can try vaginal births even for those who have had C-sections before, again, if it's low risk. There are other requirements around that, including being open 24/7, having a surgical suite, being staffed up with an RN 24/7. But I think, again, while this is helpful, we'll see how many people take advantage of it, right? If you have folks who are just closing their OBs, right, their OB departments, how many folks are going to find it advantageous to just open a place that's just for giving birth? We'll see. for hospitals, and this is an issue that's been bubbling up. That's now bubbling up as more folks are kind of wrapping their minds around what's happening here. But for ED departments, emergency departments, we know we have a lot of folks who can't get care otherwise, and so they just present at the ER when something bad happens. Now hospitals are being tasked or being required to come up with diversion plans. So as folks present to them, once they take care of whatever the acute need is, they're being required to move them on to, to have partnerships with local clinics and folks that they can move people into for more, for their non-emergent needs, right? What I think this forgets, and what we've heard from the hospital folks that we've presented with, and from the clinic folks who are now kind of being, secured as the diversion as the place where people are getting diverted to. A lot of these folks don't have insurance coverage, right? And so how can you give them care on an ongoing basis? A lot of these hospitals, there are plenty of hospitals and communities that don't have an FQHC or a free and charitable clinic clear. So what do you do in those areas, right? Any number of shortfalls. And kind of connecting to this next slide, where free and charitable clinics now also are allowed to see folks who make up to 300% of the poverty level. Let me take a step back to say, free and charitable clinics, the way they do business, right? They see, before this rule change, they could see folks who make up to 200% of the poverty limit without fear of being sued. They have sovereign immunity and are allowed to provide that care. That threshold is now moved up to 300%, meaning they're going to start seeing a lot more people. There are now more folks who can go to them to get the care that they need. The problem we're hearing from these FQHCs and free and charitable clinics is that the more people that they see, right, as a result of this, there's no accompanying funding to see these folks. So they're just seeing more uninsured people or more people on Medicaid, which has a low reimbursement. And as you can imagine, there's a certain level of fear about the pressure of it, the pressure of seeing that many people when you don't have the funds to do that at a high level. So a couple last provisions here on 7016 when it comes to community health. One of the big things was just funding to provide more community health screenings. So basically, nonprofits could apply for this funding to host blood pressure screenings and things like that in their own communities, which again is a really nice step. A lot of people will get to hear, will have that experience of understanding what might be wrong with them, or getting some indication that something's wrong with them and that they need to go see a doctor. I think where this falls short, where this doesn't go the full way, is, let's say I go get my blood pressure taken somewhere, and now I know I have a problem. Where do I go? I don't have insurance. Who's going to see me? Right. So talking to one of our partners who works with the Rural Women's Health Project, she mentioned that with her population, the people that they see, so many folks just don't go. Why would they go? They don't go seek help. They don't go to these health fairs because they don't want to know. What's the point of knowing if I don't have the means or ability to do anything about it? And so, better to live in ignorance, right? To live in the bliss that ignorance can be sometimes. I'm guilty of it, but don't tell anyone. So just to say, we have a lot further to go here. And it's just in the last couple of weeks, the Department of Health has started putting together the parameters of this program. And they did a Q&A, and they sent the answers back out to the folks who were interested in engaging in this program. And one of the things that jumped out at me as I read that Q&A is it's very strictly screenings, and screenings on these specific things, nothing else. And anything that even approaches treatment, you're not allowed to do with these funds. And so even in those settings where you're providing the screenings, you're handicapped. Like, literally all you can do is tell them you have a problem and kind of send them on their way. I think this is the last piece on community health. Again, on maternal health, in the last couple of years, we piloted a program to provide through telemedicine kind of these educational resources about pregnancy, right? So how to stay healthy, how to get a wellness check, all the things. And I guess the program itself had some success. Now it's been expanded statewide, and so a lot more people have access to this telehealth program. I think there are some challenges there. Again, it's a great step, but the obvious challenges being, if you're in a rural community, right, or you're just someone who doesn't have access to the technology that you need to log into these programs, how do you access it? How does it ultimately, how do the people who need this help actually get to it? I think is still a big question that needs to be answered. So these next few provisions I'll get through pretty quickly. 7018 on healthcare innovation. First, it creates this 15-person council whose job it is to go around the state, hear from other people about, the workforce issues that they're facing, but also any kind of promising delivery models, health delivery models, and things like that. And hopefully walk out of that process with a clear set of recommendations or ideas for the state to follow to improve our healthcare system. This bill also comes with a loan program. So those individuals or entities that are doing innovative things in healthcare delivery, service provision, they can apply for basically low interest, no interest loans to do this work. And yeah, I think encouraging that innovation, incentivizing that innovation is an important thing. So I'm excited to see what comes of it. Mental health, behavioral health is something we've talked a little bit about today. What SB 330 did was basically provide a bunch of funding to establish 4 teaching hospitals, one at USF, 2 at UF, 1 in Gainesville, 1 in Jacksonville, and 1 at UM. I like to say that just like the college football playoff, the legislature left Florida State out. That feels like a good, yeah, there we go. I got to laugh. Okay, I'll take it. That feels like a good joke to make in Gainesville sometimes, but we're having our own troubles, so I'll stop. But just to say, there was a lot of money put into these behavioral health teaching hospitals. And so the thought being, right, that we get more residents here, more people who get familiarized with Florida. But I think the challenge of retaining those individuals still exists. Then there's 1758. And this is J.J. Holmes, one of the advocates we have the pleasure of working with. Now, here's a kid who, has cerebral palsy. His mom takes him everywhere on all of his advocacy adventures, but he's been relentless in his pursuit to change the system. He contacted every legislator he could, emails, calls, on social media. He got in with Senate President Pasadomo, who, this is a picture of him being invited into the chamber. And at the end of session, all 40 senators signed on to this bill and applauded him and his mom for the work that they've been doing. And I usually highlight that to highlight the power we each have, right? In our stories and our experiences, what we can each bring to the table to ultimately push for change. And so it's people like JJ who keep me in this work and keep me inspired. But part of what he accomplished with 1758, there was some funding to take people off of the wait list. We'll see how many people that actually takes off. It lowered some of the thresholds to reach a crisis designation. So I don't know how much of this you guys know, but they're basically 7 tiers, right? Once you apply for home and community-based services. Now, if you're in tier 1 and 2, you can get off the list, right? If you're in like crisis, you're homeless and you're by yourself, you can get off that waiting list to get home and community-based services. It's basically everyone else, categories like 3, 4, 5 through 7, where it becomes really difficult to get off the list. One of the criteria is that your caregiver has to be 70 or older, right? But that feels crazy because there are plenty of caregivers who are struggling and suffering with, taking care of, doing the things day in, day out. But this lowered that threshold from 70 to 60 for category 4. So hopefully it starts to move people up the list a little bit more. And then finally, you can read some of the other things, but one of the big provisions out of this, it actually creates an online system for applying for this year. The way you applied for home and community-based services in the state was basically paper and pen and in person. You couldn't, right? It's 2024. And even I, you guys should know how bad I am with these things, with technology. But even I know that in 2024, we can get an online application system going, certainly. So we finally hit that point. I think JJ himself would tell you we have a long way to go, but really important first steps and shows the power of an individual sharing his story. Now, there were a few other bills that passed through session. There was this one on rural emergency hospitals. So again, as we try to, unfortunately, Florida is not the only state that's had to deal with these rural hospital closures. And in 2021, the federal government created this designation, rural emergency hospitals, that allowed facilities to get a higher reimbursement, basically. There was a bill that passed this year that basically establishes what it would take for Florida facilities to meet those requirements to get that REH designation. Uh, and basically, you just have to have less than 50 beds. You have to meet the federal guideline, the federal standards, and you have to be staffed up to sufficiently provide rural emergency services, which means basically 24-hour, anything that can be taken care of in 24 hours or less, right? So any basic observation, any quick outpatient services generally qualify as rural emergency services. Now, like I mentioned, the important part is reimbursement. These hospitals get, or these facilities get, basically what Medicare reimburses, which is higher than Medicaid, plus 5%. They also get a monthly facility fee of like $200,000 a month. And so it goes a long way to sustain those facilities. How many of these places? We'll see. Like how many of these REHs actually crop up in Florida? We'll see. But it's an important first step. There was also this important consumer provision. You know, medical debt, like I talked about earlier, healthcare is really expensive in the state, and it follows that we have a really big list of people, a big number of people who are dealing and facing medical debt, dealing with and facing medical debt. Now, the way it used to work, you know, you have medical debt, you can't pay it, you get sued, you have a judgment, but if you can't pay the judgment, they put a lien on your property, your real property, and can garnish your wages. This bill stops them from being able to put liens on real property, but also stops from being able to garnish wages. It also lowers the statute of limitations lowers the statute of limitations to file the claim in the first place. So whereas, you know, these entities used to have 5 years to come after you, hospitals used to have 5 years, they now only have 3, which again can be a relief to the consumer. There's also these protections in here for your motor vehicle and also any other property. It protects the first $10,000 in value of your car or whatever other big property you might have that could be where a lien could be applied. There's also these price transparency requirements. So, you know, if you need care at a hospital or at an ambulatory surgical center, they have to tell you the prices of things up front, right? They have to put them on their website so you get a sense of what it's going to cost. They also have to give you, once you've had the conversation with them, and they know exactly what they're going to charge you, they have to tell your insurer basically what it is they're going to charge. And your insurer then has a responsibility of letting you know, hey, here's what the costs are going to be and what you're going to be responsible for. So an advanced explanation of benefits. It doesn't do anything to lower the actual cost, but at least you'll know what it is going in. Last two things. There's also this website. The Department of Health is now required to build a website that has a lot of these pregnancy and parenting resources for folks. Again, good to have like a solid warehouse of information for folks to reference. But I think there's still this question of how do you get people to this resource in the first place? And then home health care services, which we know are really important. Medicaid currently reimburses, you know, home health care services, so that's not a problem. It's mostly that they only reimburse those services that are ordered by RNs and physicians. Now, this allows reimbursements for things that are ordered by APRNs and PAs. Physician's assistants. So, you know, creates a little bit of flexibility there. So as I close, you guys have been great to bear with me. Just a couple of things that Florida Voices is working on in 2025. Some of the policies, we're looking at building on Live Healthy, right? Took some important first steps, but as you heard, I think there's a lot we can be doing to really shore it up. We're working with some of the free and charitable clinics to talk about the need to fund the care that they're providing and what are the different options to do that. I talked about the Acorn Clinic and that Teach program that would be really helpful for a clinic like us. The way it's written actually randomly leaves out our little clinic. And so we'll be doing some work to try to get ourselves in there. We're still working on expanding Medicaid eligibility so that folks who are making between, right, like we talked about earlier, it's $8,000 is that cap. We're hoping to get that up to about 10 to, well, if we did a full Medicaid expansion, it would really cover those folks who make between $10,000 and $35,000 for a year. They'd have that access to care that they don't currently have. I didn't dive into it a whole lot, but Medicaid currently, when it comes to dental care for adults, basically the only thing you can get is a tooth pulled. It's just an extraction. I think maybe you can get one denture in your lifetime, but we all know how dentures change and shift and the whole thing. And so, yeah, it doesn't do enough for the people who are currently in it. And so we're working to expand the benefits that are provided through Medicaid. Oddly enough, the insurers a couple years ago, side story, a couple years ago, went to the state of Florida as they were negotiating these contracts and said, hey, we'll provide these expanded benefits at no extra cost to the state. Who believed it? I don't know, not me necessarily, but they took the deal, right? Here we are years later, and basically that care isn't being provided because they aren't getting funding for it. And so, yeah, it's just one of those things where we're hoping to codify that requirement, but also get some of the funding that's required to provide that care. Last thing I'll mention is Florida ranks 41st, I think, in Medicaid reimbursement. So we only pay a fraction of what it actually costs to provide care. Yeah, to Medicaid, and you can see how that might be unfair for providers. We're continuing to work towards funding the iBudget waitlist to try to take all 22,000 people off of the waitlist. And one of the issues that this last point about parental consent for health screenings, I'll talk about that bill specifically in a second, but just to say it's a really good example of how we try to do the work. We let people come to us with whatever their stories and issues are. And this was actually a couple of parents, but who are also dental health professionals. And Tina works for UF. Her job is to go into schools and provide these health screenings, right? But she noticed that after a law change a couple of years ago, the Parent Bill of Rights, that a lot of counties have taken, even though they're still allowed to provide these screenings, they've taken this approach to really protect themselves where they're requiring active consent just to do a screening. So just to look into a kid's mouth to say, hey, you have cavities, you should go see a dentist. Now they require a signed note from a parent to actually do that. And as you can imagine, it's not that parents are writing back and saying, oh, no, don't do this. They're just never getting a letter back. There's never, yeah. As hard as it was for me as a kid, me at this age even, to get like notes home the way I should, you can imagine how much little kids might, how it might not get to the places it needs to. And so we're working with a couple of legislators to actually, to make clear that a passive consent is okay for school health screenings. And the last thing I'll say, I talked about Medicaid expansion a little bit, but just to drop a note, it's been a really hard thing to do here in Florida, right? To like actually get folks to consider Medicaid expansion. But in this last legislative session, we had a little bit of momentum that I don't think we've had these last few years. We connected with Representative Dr. Joel Rudman, who's a Republican based up in Navarre, Florida. And he was the first person to come out, like, to say out loud in a long time, hey, we need to expand Medicaid. And it's because he provides care in a rural community and sees the difficulty that it is to actually do that and sustain, right? And how many folks are left out of care. And so we've been working closely with him to really talk up the issue and bring some new people into the fold. And yeah, we don't always get to where we need to, but it's led to a lot of productive conversations that we haven't had before. And then it's through that partnership, actually, we were able to bring down Republican Senator Kevin Corbin from North Carolina, where they just expanded Medicaid last year. And he came down, we, hosted him for a couple of lunches and things like that. He walked the halls of Tallahassee and met with a lot of leadership, so this incoming leadership, and just talked to them about the benefit that expansion's been for North Carolina, particularly their rural areas and hospitals. And so just to say that conversation's bubbling up, and yeah, feels like there's some momentum. And I'll talk a little bit about the ballot initiative in a second, but yeah, just to say some good things are happening. Now, as I try to, you guys bear with me because this is where I try to sell you the timeshare, basically. As I try to like pull you into the work, ways to do that. We're a storytelling organization, and so it's all about empowering people to share their own experiences. And I dare say folks in this room have their own stories to tell. So if you're interested in telling a story, regardless of what it's about, feel free to reach out. If you know others who have stories to share, feel free to connect them to us. One of the things we don't do a whole lot of currently are issues that are impacting seniors, right? And so I'd love to hear from you all. What are the things that are important to you? And that you want to do something about, and we're here to be a resource and to help you accomplish that. Other ways to get involved. We have this little coalition, Healthcare for Florida. Acadia Jacob, the redhead in the middle there, she really leads our folks up to Tallahassee. We try to have a presence up there every week during session. We help folks to travel. We provide travel stipends and a place to stay and the whole thing. So yeah, if you're interested in walking the halls with us, we'd love to have you. We also hold this space called For Florida's Health, where we have a great partnership with a lot of the major disease groups. So American Heart Association, American Lung, Susan G. Komen. Yeah, you can see a bunch of them listed here. And basically, we just work together to talk about the issues that are happening here in the state. The benefit of being in that group is we try not to be too political one way or the other, right? Like we just talk about the issues as they exist and try to pull more people into it. The work that we'll be doing this year and next is trying to bring in more kind of like law enforcement and city local officials, city and county officials into the work. So yeah, if you're interested in being a part of that, we'd love to have you. And then the ballot initiative. So although we've been banging our heads against the wall for like the last 10 years trying to get expansion done, it's slow going to say the least. But we also have this option. Since we're one of the last 10 states, of those remaining 10 states, I think we may be the only one that actually has this ability to put the question on the ballot, to pass it as a community, right? As residents of the state, voters in the state. So what we're trying to do is collect 1 million petitions before January or February 2026. Petition collection is already happening. I know Phyllis and a group of strong women are already doing that work here. A lot of our partners around the state are already doing this. And so would love to have you be a part of that work in any way. Yeah, you might be interested. And happy to answer any more questions about that. Just going to skip through to the end here. I talked a lot about the work that we're doing on oral health, and we have a Florida Oral Health Alliance. We do some policy advocacy, but there's also this community outreach piece, right? Where it's empowering people in communities to, I don't want to say take care of their own health, but giving them the tools to stay healthy. And so we launched this Florida Dental Access Guide, which is an online platform where folks can get access to information on, how to take care of your oral health, but also how to navigate the systems to get coverage and to get to the care that you need. And then finally, if you just want to stay plugged in with Florida Voices, we have a mailing list where we send out updates, generally speaking, and invites to our events. We also do during legislative session, we have a policy tracker where we keep track of every piece of like healthcare legislation that's moving, and so you can reference that week to week. We also host a monthly phone call where people just get policy updates from us on whatever's timely, whatever's happening. And I'll also cancel the call if there's nothing to talk about. So yeah, just know that I'll never invite you to a thing if there's nothing to do or talk about. Yeah, that's us. That's Florida Voices. Thank you all so much, because that was long, but you hung in there.
Thank you, Scott. We have questions, discussion. Okay, I'm going to start on the left here.
Hi, thank you so much for a really fine presentation. I really like the fact that you provided lots of details, that you really got in the weeds here, because I think that's what it's about. It's actually what you're seeing in the healthcare system today rather than the big general issues. So we really got into the weeds, very granular. So I like that. Friend of mine just moved to Melbourne from Nashville, Tennessee, and she said, well, the healthcare is worse here. So I'm on waiting list forever at serious things. My husband, same thing. And I said, oh my gosh, it can't be worse than Tennessee. And she says, no, I swear it is. But it got me thinking about how in many ways, Florida has never gotten past thinking that it's a small southern state, and that it's never really caught up with the fact that in terms of population, it's got challenges facing it that are really tremendous. And I think that what you have shown is that the legislature has produced a really interesting but very complex patchwork of solutions to very specific problems. And there's no sense there, at least from what I can see, that there is a long-term plan in place. And what I'm interested in is anybody besides you and some academics doing long-term planning that legislators are aware of, because it seems to me that they don't know the enormous, the population growth, revenue issues, all of those things, that they should have a clear sense of what's happening 10 years down the road. So I guess what I'm saying is, it seems to me the legislature is doing a lot of incremental work, like with your disabilities advocate, but it's not really thinking in terms of it's kicking the can down the road. How about that?
No, that's fair. So a couple of points, right? Or a couple responses to that, because I think that's spot on. First, it's this phenomenon of people who move from other states and get to Florida and find out the hard way how bad the system is. So many of the folks who reach out to us this happens like at least once a week, once every 1 or 2 weeks. We get a parent of a kid with a disability who's either already moved to Florida or they're considering moving to Florida. And they it's the ones who are considering moving who are like, hey, can you give me any advice like on how things are going to be and what I should do, who I should contact? And I try not to in that setting, because we're not the complete experts on everything disabilities, but it's at that point you want to communicate that, hey, things are going to be different from whatever state you're moving from, and very likely more difficult. And it's those folks who have already made the move, who for one reason or another are already down here. Maybe they have more family down here, and so they make the move, but then find out how little supports there are in the system overall. And then to your point about, is anyone doing long-term thinking? No, is the easy answer. And that's what's missing, right? And I think there are a couple of things driving that. One, you have a legislature who's just, right, they're citizen legislatures. Is that the phrase? So folks who have expertise in any number of industries, not all of them certainly, and very few of them healthcare. And the ones who don't have healthcare, what's concerning is how many of them think they're experts in healthcare anyway. And so that's a phenomenon. Yeah. And then, right, we have term limits and elections. And I think that's what keeps people in this cycle of, hey, I just need to do this thing to get to my next election and get past that. And no one's willing to push in that bigger, more comprehensive way, because it takes more time. It takes, right, more explaining. It makes it less likely in their minds to be voted back in. So yeah, those are the dynamics we're fighting against there. But it's a great point.
Thank you. This has been terrific. But I have a question that just came up with a friend relative of mine in the past couple weeks, and he ran into something with a ongoing problem. Has insurance, has Medicare, and he's one of those single people who can't get Medicaid and should get it. But the problem is that he's been going for treatment to a site in South Florida, and suddenly he got enormously large, bit more billing, and he was told, "Oh, well, that site is now considered part of the hospital. We've designated it part of the hospital, and therefore it's outpatient. And instead of being at just a doctor's office or a clinic, now it's outpatient, and we can charge you triple or whatever, or even more." And he's fighting a lien on his house now.
No, it's terrible. That's
For-
absolutely terrible.
for
Yeah,
profit. For-profit healthcare.
yeah.
The hospital is loading its overhead costs onto the individual.
That's it. Yeah,
Yeah.
that's the phenomenon. Yeah. I would bet that hospital just entered a new ownership, right? That's probably a private equity. Yeah, private equity is a whole thing that's happening in healthcare. To Phyllis's point, that's really driving a lot of that.
Great talk. I have 5 questions, but I'll just shoot
Go for
one or
it.
2 at you. um, okay. The opposition to Medicare expansion, I guess I didn't quite get. I know you get a lot of federal money when you adopt this, but what is the impact on the state? Is that really the opposition? Is just the increased cost to the state?
So I'll tell you what they say, and then I'll tell you what happens, right? So the common thing is Florida can't afford it. Why would we pay this additional money? And the thing about Medicaid expansion is, on the one hand, I talked a little bit about the split, how it's 60-40 currently. under expansion, that split becomes 90-10. So the federal government pays 90% of the cost, the state only pays 10% of that cost. Now, when you factor in the 10%, who was it that said patchwork? The word reference patchwork. The way we provide care now, it's a patchwork, right? So we pay for people in emergency rooms. That's all of us paying taxpayer dollars to take care of folks there. We provide care in prisons. That's again patchwork. We have little programs that have been carved out over time where we're like paying out in these like very unique circumstances where people are at the end. Now, if you factor in what Florida's would pay as part of that 10% and the patchwork that it would eliminate, right? It takes a little while for that to happen, but for reduced emergency room admissions for people who are completely uninsured and the whole bit, Florida actually ends up saving $200 million a year. That includes Florida's contribution. And I say that, right? And I can throw those numbers out there and people might say, oh, well, that's hypothetical. The problem is we're last 10 states to do it, one of the last 10 states. And maybe the only benefit of being at the end like that is that we've seen this experiment play out in 40 other places. And so what we come up with isn't so much a guess, but it's based on the very real experiences and numbers that we've seen in other states. And so I can say very confidently that Florida actually saves $200 million a year if we were to expand Medicaid. That's not including the last thing I'll say. We've had a couple of bills pass since then, right? Like the American Rescue Plan. All these federal bills that have come down, they include financial incentives for states to take up Medicaid expansion. I think Florida stands to get a $3 billion cash payment just to expand. Nothing else. Here's $3 billion to expand. And that doesn't touch the 90-10 split or anything like that. So you often hear costs, but that's not true.
So you might want to slide with that.
Yeah, I try to, I'm like trying to pick my spots. I didn't, because this could have been longer. Imagine it.
I'll toss one more at you. Obviously, people are doing studies on retention of medical staff, and you find that many are leaving the state. If you're doing studies, you must be asking why. Why are medically trained people getting trained here and then leaving? What are the answers?
So the conversation I had the other day with this gentleman, it's part of a project that I believe the governor himself, but also the Florida Board of Governors, so like the higher education folks, have put together this project to really, he reached out on the specific question of dental access for people with special needs. And it was in that conversation where he mentioned this retention thing. And so one of the questions he asked me was exactly what you asked me, which is why? Like, why are people leaving? And I mentioned that to say that I think they're still trying to figure that out. I think everyone's still trying to get a sense of it. In the conversations I've had with providers and everyone else, I think what I've picked up on is Florida feels a little bit more restrictive for providers to, right? Because a lot of people who get into this industry get into like provide care to actually not to become rich, but to like do the thing of like, yeah, getting care to people who need it. And it's harder to do that in Florida in, some instances. We haven't expanded care. We have such a high uninsured rate. There are a lot of people who can't get in. And so I think for one reason or another, that's hard for physicians to like accept. So I don't know how much that specific phenomenon is a driver of like the overall thing, but that's in my little corner of the world. That's what I've picked up on. I'd be interested to know, more comprehensively what's driving that.
I was talking to a cardiologist who was expressing disgust at the fact that Shands had one of the top heart surgeons in the country, but he left because they weren't paying a competitive salary for him. And then that cardiologist left Shands, and then another cardiologist left Shands. I have a mild heart thing. So these are cardiologists that I see and I like. And where do they go? To the VA hospital across the street.
Yeah. Yeah. No, competitive pay is a thing.
Apparently.
Yeah.
My primary care practitioner went over to the VA.
And Florida's one of these places too that's like we talked about private equity. Yeah.
So I've met people who move down from other states like Pennsylvania, and then they start complaining about the lack of services. And I said, yeah, but there's no income tax. And, all you pay to the state is a sales tax. And why are you complaining? Taxes are low. That's the whole point here in Florida. and there's this libertarian philosophy. And so Rick Scott privatized the processing of Medicaid. And I had some personal experiences with my mother in a nursing home. It's so let me ask then. Stop talking about my own experiences, but what exactly does Medicaid expansion mean? Okay, so we get $3 billion from the feds, and then what? I mean, what does that imply about actual care?
Yeah. And the way I like to talk about Medicaid expansion is like it's one big piece. It's the biggest opportunity we have to get more people this ticket, right? The ticket into the door. But I don't think it solves the problem. I don't think it fundamentally fixes all the things that are wrong with the system. Medicaid reimbursement rates, what doctors get paid to see patients on Medicaid. I'll say that the only thing better than like, or the only thing worse than like low reimbursement is no reimbursement, right? So better that the uninsured folks have Medicaid coverage and doctors are made, given some kind of remuneration for providing that care. But there's still this issue of reimbursement rates being a fraction of what it actually costs to provide care. And so you have providers who aren't willing to be Medicaid participants. You then think about what it takes administratively to become a Medicaid provider and how many hoops you have to jump through just to become recognized as a provider, and that turns a lot of folks off. You have facilities that don't exist, right? Like, so places where even if I wanted to serve this community, right, as we did these roundtables, we found out that you'd have specialties who would come house in these facilities, right? So maybe there wasn't a cardiologist who lived in the area, but would be there 2 or 3 times a week, and that would be an access point. But if you don't have the physical location, where are they staging? So it's just to say that there's so many other parts of the system that have to be addressed at the same time. And so we try to talk about all the things at once, but it's a really great point.
So
I just want to, it's just a comment. My stepson went to school here in medical school. He's a psychiatrist and works with the poor and homeless in North Carolina, and doesn't make a fortune, but he's very happy doing it. But he couldn't be here because in North Carolina, they help fund this big thing to help the poor, and we just don't do it.
No, that's what it is. I think that's true of so many people who go into the medical profession, right? Like, they're not doing it to become rich. It's a perk, sure, but it's not the main motivator. And so if you're in a place where it feels like you're being hampered from doing that at a basic level, then what's the point, And folks, I think, just find other opportunities.
we have a question from Zoom. What impact has the Florida abortion ban had or is projected to have on attracting and retaining providers of reproductive health?
Yeah, no,
Well, that's a loaded question.
I don't think it's, a positive impact. Right. We've seen all the commercials, and I think we all have a sense of, if you're a physician and like this is the training you've received to make certain decisions to like help people the way you see fit, and you're unable to do that, then Florida maybe isn't the place you choose to practice.
Well, I don't know about Florida specifically, but I've read about other states like Mississippi where the gynecologists and obstetricians are literally leaving the state.
And it's the last thing we can afford here.
So I would presume that that's what is happening in Florida as well. But at the same time, you were citing some statistics there about maternal death.
It's pretty bad. Yeah. The last thing we need is more providers like leaving. Yeah.
Wow. Well, okay. Well, this lady, one more.
I know in presentations like this, people like to have fantasy questions thrown at them.
Yeah.
So I'm going to ask you to fantasize a little bit. What do you think it would do to healthcare costs in Florida if we had single payer healthcare?
That's a great question.
It's a fantasy question, isn't it? But I'm curious. I don't know what the answer might be. So
I'll say this, right? In Massachusetts, all those years ago when Mitt Romney was governor, they found a way to provide healthcare to everyone, to have like a near zero uninsured rate, and the state still exists. It's not, Massachusetts isn't like underwater, both like for real and metaphorically.
Having lived in Massachusetts, I can vouch that the taxes are very high.
Well, there's that. So it's right. It's always a question of like where it's got to get paid for. Maybe that's underlying all of this. It's like healthcare isn't a free thing, and so it shouldn't be. There shouldn't be this expectation that like folks are going to provide it for free and that we should all receive it for free. I think we all have something to put into it to like pay. The way it becomes, because we're all going to pay anyway, the way to do that efficiently, when you think about, I had the like pleasure of taking like an insurance law class back in the day, and it's all about risk pools, right? It's all about like finding ways to like group people. And as a small example, in states that have expanded Medicaid, what people are paying for private insurance, so unrelated to like folks enrolled in Medicaid, it's 7% lower in those expansion states than in non-expansion states. So just to say that if you take care of your risk pools, for lack of a better word, your population in a more comprehensive way, everyone benefits from that. I don't think that's just numbers, you know? And so what would it look like in Florida? Hard to say, but I would bet that like if we're all kind of paying into a system where we're all, responsible to each other in that way, then yeah, I think it works out in the end.
I'm from Massachusetts too, and I can vouch for Mass Health, and it is wonderful. The supportive care services are excellent up there. My sister has developmental disabilities, and she is so well cared for. Unbelievable. I was kind of curious, since I've just moved down here, there seems to be an ER facility on every corner, like there's Starbucks. And then I'm hearing you say Shan's closed 3 facilities. What is with all these ER facilities, and are they all making money? And
The
why are
ER
there so many?
Yeah, no, I think they do. Right, because they provide that limited number of services. A lot of them see kids, and typically services for kids are reimbursed at a much higher rate. They can like be really selective about the care that they provide and like structure that in a way to where it's really the money makers. You know what I mean? It's not like they're not providing a bunch of indigent care is the term people use. So they're not providing a bunch of free and charitable care. It's just money. Yeah, I don't know how else to put it. They get a lot of private pay folks, a lot of private insurance folks, and so it works. It's a model that works. Private equity, I mentioned earlier, is a big thing that's happening in healthcare, and that's to say that you have these right like funds that are coming down, buying up hospitals, buying up ERs. Yeah, kind of making them as profitable as they can before they like sell them off. And so I think ERs are a part of that mix, the standalone ERs, but they don't provide the comprehensive care, the ongoing care that people need, or see low income folks.
Well, thank you so much, Scott.
Yeah.
That was
Yeah.
very educational. And we wish you well in your efforts.
One last plug. If you guys are interested